Alright, so yesterday we left off at Clostridia. We talked about all the other gram-positive up to here, though. Talked about all their different features, things that help you identify them, problems they cause, and how to treat them, right? Definitely one of the most sophisticated ones was the strep pyogenes. We talked about all the different presentations you can get, and now we're up to a different group of sophisticated spore-forming anaerobic gram-positive bacteria, and that's the group of all the Clostridia bacteria. So the Clostridia guys are obviously very high yield, especially tetani and botulinum, but definitely you can get a question on any one of these guys, right? So you have to understand how they work, what they cause, what kind of patient that you're supposed to suspect Clostridia infection in. So let's look at it. Gram-positive spore-forming obligate anaerobic rods, right? So they're obligate anaerobic rods. They do not want air. They don't want oxygen. Tetanus toxin and botulinum toxin are proteases that cleave snare. Right? So you need to know what snare is. If you don't, you should definitely Google it, learn more about it, right? Because they don't talk too much about it in the book. Snare proteins involved in neurotransmission. But, for the basic part, what you do need to know is that it's involved in neurotransmission. And that's definitely good enough. Neurotransmission is a big part of tetany. So C. tetani produces tetanospasmin, an exotoxin causing tetanus. Tetanospasmin blocks the release of GABA and glycine. We talked about GABA and glycine a lot when we were doing biochemistry earlier. From Renshaw cells in the spinal cord. And this image on the right over here is for C. tetani sketchy micro. So C. tetani causes spastic paralysis, trismus, rhizus sardonicus, and epistatos. So you can see all these monkeys here that are presenting with those symptoms. You prevent this with a tetanus vaccine, but you also treat it with something similar to a vaccine. You treat it with an antitoxin, right? Because the issue isn't that the bacteria itself is the guy causing the disease or anything or causing the symptoms. It's the toxin it releases that causes the symptoms. So you have to give antitoxin. And anytime treatment is about giving antitoxin, you need to give the antitoxin ASAP before the toxin can actually go ahead and carry out the symptoms it's going to cause. You also have to give vaccine boosters for C. tetani vaccine because it's not a vaccine that has a protein attached to it, so it's not going to be that immunogenic. It does wear out, right? So you get the tetanus vaccine every few years for the most part. You also give some antibiotics. Diazepam is for supportive help for the muscle spasms, right? And wound debridement. So the wound part is a huge play in C. tetani. There was a question on UWorld about C. tetani where they were like, how would you approach this patient? And the answer was to immunize the mother with vaccine and manage the neonate, and history and physical were key, right? So for that question, it was a whole different thing, but what was really standing out in that question, and they stressed it in UWorld, was to get the history and the physical, right? Someone presenting with spastic paralysis, if they have a wound, then you can start thinking, okay, they might have gotten a puncture wound from some kind of metallic thing, and then, got Clostridia tetani. Tetany is found in soil and invades the body through wounds to travel retrograde to the spinal cord. The toxoid vaccine is for prevention of neonatal tetanus and tetanus overall. Right, so it's a toxoid vaccine. It's not that immunogenic, but it can get the job done. So let's take a look at the sketchy micro aspect of this. Let's see what they have to say. Right, so this is your G&G stuff from sketchy micro for C. tetani, right? So they call it the Rhesus Research Revolution, right? So this is a research factory, obviously, a bunch of monkeys that you would do research with and 2 researchers. The violet hues, everything being all purplish, is to remind you it's gram-positive. The main researcher is suited up because Clostridia are obligate anaerobes, right? They're obligate anaerobes. So they're all suited up, and on top of that, this gas mask is there to remind you that, right? So this gas mask reminds you that, and anytime you ever see a gas mask, it reminds you that this is an obligate anaerobe. They cannot really breathe, right? Although a gas mask is usually associated with breathing better, in this scenario, they're not like in space or anything, right? They should be able to breathe just fine without the gas mask. So there's something they're trying not to breathe. That's how you want to see it, right? Obligate anaerobe. The nuts on the bottom right are a sign of sporulation, and anytime you see nuts on any picture, they're always about spores. We saw that in the basilisk guys as well. Tetany is found in soil and needs to get under the skin by rusty nails or barbed wires seen in the image, right? So you have your rusty nails that you can step on. I've been there. I did that in India. I was running around. There was a nail that actually went through my shoe into the sole of my feet, so I had to get the antitoxin at that very moment. Tetanus causes a spastic paralysis with muscle contractions leading to rigidity, while botulism causes flaccid paralysis. So there's no rigidity there. It's the opposite kind of paralysis. You're unable to flex there, whereas here you're unable to stop flexing, right? So when you think of unable to stop, you want to think of lack of GABA, right? Because GABA is generally inhibitory. A common manifestation of tetanus is rhizus sardonicus, a malevolent smile that the monkey on the right has, like this, right? The facial muscles all end up contracting. The monkey with the arching back depicts epistatos, so that's this guy right here. Tetanus toxin travels retrograde from the motor neuron to the spinal cord, depicted by the pulley. Right, so that's not exactly entirely going to do a good job, but it does work. So basically, this pulley would work backwards in lifting someone up, right? So this is what's happening with this pulley right here, right? Because right now it's already on the floor. As soon as it activates as a trap per se, it'll cast the person in this manner. The toxin is represented as a scissor because it's a protease that cleaves a snare, inhibiting exocytosis of the neurotransmitter into the synapse, depicted by the snare trap. The two G's on the people is to tell you the cleavage of snare leads to inhibition of GABA and glycine. That's what the G's are supposed to remind you of. The Renshaw cells sense overactivity of nearby motor neurons and inhibit it by releasing GABA and glycine, depicted by the wrench and a saw, which again is not a very common thing for them to do, to draw things that are that literal. But that's what the wrench and saw in this guy's hands are for. There's obviously no construction happening. So these monkeys represent the Renshaw cells that are supposed to do the job, but won't be able to. That vaccine is a toxoid vaccine. Tetanus toxoid can be given with reduced diphtheria toxoid and acellular pertussis vaccine all together, right? The Tdap, tetanus, diphtheria, and acellular pertussis. Or you can get DTaP, which is diphtheria, tetanus, and acellular pertussis. Same thing, different names. They're both the same exact vaccine. All right, so the DTaP or Tdap, this vaccine takes care of all three of those issues at the same time in one vaccination. All right, so that's your C. tetani. So spastic paralysis. Spastic paralysis after being punctured in the skin with some kind of metallic thing that would bring the C. tetani into the person. This image over here, this one is for Clostridium botulinum. Right, so let's look at the next guy, C. botulinum. Right. Okay. So C. botulinum produces a heat labile toxin that inhibits acetylcholine release at the neuromuscular junction. And inhibiting acetylcholine release at the neuromuscular junction should remind you of the neuromuscular junction diseases like myasthenia gravis and Lambert-Eaton. Very similar thing happening here as well, right? And here the real issue is not making acetylcholine at all, or not being able to release acetylcholine at all. In adults, the disease is caused by ingestion of preformed toxin, while in babies, the ingestion of spores leads to disease. Treat with human botulinum immunoglobulin. Now, this is a big difference you have to remember because I've seen it pop up in questions, right? So in botulinum, if a couple or family is presenting with flaccid paralysis symptoms, consider that they may have eaten improperly cooked canned foods. Repetitive nerve stimulation improves deficit by increasing calcium and acetylcholine. And this repetitive nerve stimulation we've seen in the myasthenia gravis and Lambert-Eaton scenarios as well. Repetitive nerve stimulation, now to memorize myasthenia gravis and Lambert-Eaton, just remember that in Lambert-Eaton, something is eating your acetylcholine, right? Whereas myasthenia gravis is very grave. It's very grave. So in Lambert-Eaton, something is eating your acetylcholine, but repetitive stimulation leads to more acetylcholine release, and then you can do better. Whereas myasthenia gravis generally just tends to get worse with the day, right? So this one is more similar to Lambert-Eaton kind of thing, right? Where the repetitive nerve stimulation is going to help. And this kind of comparison between diseases and two different things that can cause similar symptoms is a very common thing on step 1. So you want to make sure you remember that. But the difference between adults and infants getting the same disease is a big part. So adults only get C. botulinum when they ingest preformed toxin, not when they ingest the spore, right? Adults do ingest the spore. Adults are allowed to eat honey all they want, right? But for kids, you avoid honey, right? In little babies, neonates, you don't feed babies honey because spores ingested by the babies actually leads to the spore germinating and then releasing toxin, causing floppy baby syndrome, right? C. botulinum is floppy because they're unable to flex, unlike C. tetani where you can't stop flexing. So botulinum is from bad bottles of food, juice, and honey, causes a descending flaccid paralysis. Local Botox injections used to treat focal dystonia, achalasia, and muscle spasms. Also used for cosmetic reduction of facial wrinkles, right? Botox is botulinum toxin, where you can cause the wrinkles to go away because those parts of your face or any of these other spasmic issues, those things stop spasming, they stop flexing. So in the image themselves, you can see the same guys here again to remind you of Clostridia characteristics, right? So anaerobic. The nuts over here are no longer the walnuts, but they're now bolts and nuts. But the nuts still remind you the same kind of thing, which is that they are spore forming, right? Everything's still purplish because it's gram positive. The robots have a can for their body to depict that improperly canned foods transmit spores with preformed toxins that will flourish in its anaerobic environment inside a can. The walnuts are now nuts and bolts, representing the spore-forming characteristic. The guy on the right with his mask symbolizes obligate anaerobe characteristic. The robots are going limp, representing the flaccid paralysis, which clearly is starting from their neck and going downwards. Right, so you can see like this guy, some of these light bulbs are actually on, right? For this guy that's functioning just fine, all his light bulbs are on. But here you can see the head and ear parts have turned off. This one, even the shoulder ones have turned off. So it's going downwards from the head down. So it's a descending paralysis. The robots are going limp, representing flaccid paralysis, which is clearly starting from the neck and going downwards. Descending paralysis, as opposed to the ascending paralysis of Guillain-Barré. Right? Guillain-Barré is an ascending paralysis from the legs upwards. Diplopia and ptosis may be first symptoms, so their eyes are closing. Children get botulism from honey. Botulism attacks motor neurons that release acetylcholine, inhibiting its release, and this is depicted by the power supply on the right. The guy is holding the same scissors as in tetanus because the toxin is again a protease that cleaves snare. The baby represents floppy baby syndrome, the little baby robot. Adults do not get infected by ingesting spores because our intestinal flora can actually beat it. But babies have a sterile intestinal flora that can't beat the spores. Botulinum spores are commonly found in honey, represented by the robot pouring honey-looking oil. Right, so this is actually oil being poured all over this robot, but it's very obviously looking like honey being poured all over him. Botulinum spores are commonly found in honey, so that's why this makes sense right here. So babies get floppy baby syndrome by ingesting spores, while adults get botulism by ingesting preformed toxins. The infant's stool will have bacterial toxins, and you're going to see that in the question. All right. So very, very big difference that you want to make sure you grab there between the adults and the children. The type of paralysis between tetany and botulinum, and then the type of paralysis between botulinum versus Guillain-Barré, right? So ascending versus descending, and this one was descending botulinum. The next two are not proteases, so they cause different kinds of symptoms. This one here, Clostridium perfringens, right? So this one produces an alpha toxin, which is actually a phospholipase known as lecithinase, and it can cause myonecrosis, which actually leads to gas gangrene, and that's what you're seeing in image A here. Presents as soft tissue crepitus, as well as hemolysis, and that's what this plate over here is showing you. A very unique kind of hemolysis that I'll talk about soon. If heavily spore-contaminated food is cooked, but left standing too long, the spores germinate, and then you get vegetative bacteria, which produce heat labile enterotoxin, and that leads to food poisoning symptoms in 10 to 12 hours. Resolution by itself within 24 hours. So this is now the third food poisoning we've seen, right? Yesterday we talked about Staph aureus food poisoning, right? And that was related to mayonnaise and meats. We talked about Clostridium bacillus and Clostridium cereus, and Clostridium cereus was the one that caused food poisoning there, where it was mostly just watery food after eating reheated rice, right? Because the reheated rice was getting germinated. Here, it's any reheated food that was left standing for too long. So maybe at a picnic, and 10 to 12 hours later, very similar to Bacillus cereus, it will cause food poisoning and then self-resolve. Okay, so picking between the two is really going to depend on what the question is telling you, and if they give you any characteristics of the bacteria itself. So let's take a look at this sketchy micro image for Clostridium perfringens, and let's see what they talk about, because there's a lot they talk about that they didn't mention in the book itself. So Private Ringen's motorcycle crash. This is a army guy kind of thing. Alright, so two classic presentations of motorcycle accidents and deep wounds from military combat, which is very critical, right? So the book didn't mention this at all, but you do want to watch out for that in a question stem. So if you have a motorcycle accident or a deep wound from any military combat, so that's both depicted by this private who fell off of a motorcycle. The exposed wounds allow the spores in soil to enter, depicted by the walnuts in soil pots, right? So you can see the walnuts on the bottom right over here, and all the soil pots that fell over. The gas mask that fell represents that it is an obligate anaerobe, which is true for all of these guys, right? All Clostridia are obligate anaerobes. There are two diseases, gas gangrene and food poisoning. Clostridial myonecrosis causes gas to form under the skin, which presents as crepitus from the organism consuming carbohydrates, depicted by the black smoke. Alright, so very important to watch out for that. This black smoke here and the image A we looked at earlier are things that will be described in a question. Not the black smoke per se, but the fact that the carbohydrates are what are being consumed by the organism, causing a gas to form, and there's crepitus. This is helped by the alpha toxin, which is a lecithinase that damages cell membranes by cleaving phospholipids, and that's depicted by the clothing line. So you can see the clothing line up here. It looks like the cell phospholipid bilayer, right, of a cell membrane. So you can see these phospholipids kind of resembling, the clips resembling phospholipids, and it's holding up this piece of cloth right here that says alpha on it. So this is supposed to remind you of the alpha toxin, which is a lecithinase, right? Some of the clips are falling out of place because the guy crashed and hit it. So that's supposed to keep in mind to you the lecithinase that is causing the issues in perfringens. This causes hemolysis in red blood cells, depicted by the tomatoes, right? All these tomatoes that are bursting open. But it's a very special kind of hemolysis. This also creates a double zone of hemolysis on red agar in vitro with an anaerobic environment, depicted by the double fine zone street sign, which is a pretty common thing in America. This is a real sign, double fine zone, which occurs in places where you're supposed to drive slowly, right? Maybe there's construction going on or something's not correct here. So signs will be put up saying fines are doubled, because if you're speeding here and there's people working, it's dangerous, right? So double the fines and people won't risk speeding. So it kind of works with the story too, because speeding leads to accidents, and accidents are a big thing for this question. So you want to watch out for that. So double zone of hemolysis kind of looks like this thing right here. So you can see there's an inner halo and then another outer halo. This double zone of hemolysis is very unique to perfringens. Doesn't really occur with any other bug that we will see. First line of medications is penicillin, which is depicted by this angry woman that's about to write him a freaking bill for the tomatoes he damaged, right? The food poisoning is late onset because the ingested spores must germinate in the gut and release their toxin. Very much, similar to, but also different, and we're going to see. So this is not a preformed toxin like B. cereus or C. botulinum. The knocked over slow street sign depicts the slow onset, and the dirty brown liquid depicts the watery diarrhea, which won't require treatment because it is transient. So the only real difference from Bacillus cereus and C. perfringens is, in terms of the food poisoning, is the fact that this is going to take a while longer, because in Bacillus cereus the toxin is already formed, whereas here you have to wait for the spores to germinate and then form. But remember that that difference isn't that clear, because the spores are germinating on the food that was already left out. So the toxin is already going to be formed by the time you eat the food. We're assuming this is food that was cooked, had the spores, it was left standing after being cooked, so the spores germinated, now the toxin is ready, and then you eat the food. right? So food poisoning, 10 to 12 hours is not that far apart from what we see here, Bacillus cereus, right? GI pain within 8 to 18 hours, food poisoning. But the vomiting occurs within 1 to 5 hours, right? So there's the vomiting aspect of Bacillus cereus that you have to remember, because we saw that in the Bacillus picture, right? This guy is eating reheated rice and he's vomiting. We're not quite seeing diarrhea in the picture yet, right? But it does cause watery diarrhea. So that was a big difference between Bacillus and Clostridia food poisoning. You're obviously going to have both answer choices in that question, so choose wisely. Now, C. difficile is definitely much more high yield than perfringens. It shows up a lot, especially because of the pharmacology of it. So it produces two toxins, toxin A, which is an enterotoxin, and that binds to the brush border of the gut and alters fluid secretion. Toxin B is a cytotoxin, which disrupts cytoskeleton via actin depolymerization. Both toxins lead to diarrhea, right? And you're going to see pseudomembranous colitis, right? So this is what they're seeing in a colonoscopy. They're in the colon. Often secondary to antibiotic use, especially clindamycin or ampicillin, associated with proton pump inhibitors, right? Because proton pump inhibitors lower the acidity, whereas clindamycin and ampicillin kind of get rid of the normal flora of your colon. Diagnosed by PCR, polymerase chain reaction, or antigen detection of one or both toxins in the stool. If you find these toxins, then you know C. difficile. Complications include toxic megacolon. Right, and toxic megacolon we really only saw when we were looking at the reduvid bug that had megacolon issues to it. But it's not really something that pops up in questions a lot with regards to C. difficile. Right, so treatment of this is what you really get questions on a lot. Right, oral vancomycin, metronidazole, or something special known as fidaxomicin. Right, and this has questions in UWorld. Fidaxomicin is a question that pops up in UWorld, and I have the question right here. But we'll get to that. For recurrent cases, there's another issue. For recurrent cases, consider repeating prior regimen or fecal microbiota transplant, which basically means that you're taking all the normal flora that are supposed to be in the colon from one person and giving it to this person's flora. You're recreating whatever's supposed to be in their colon by taking it from another person's colon. So, it's kind of weird, but it does the job, if anything. So let's take a look at the sketchy micro image and see what they talk about in this image. There's a lot going on. But that's because there's a lot involved with C. difficile. So let's see. The walnuts on the conveyor belt represent the spore-forming characteristics. So you can see the walnuts right here on the right side. This is a nosocomial diarrhea and is transferred patient to patient unless a thorough wash with soap and water is done, and doctors should wear non-sterile gloves and a gown while working with these patients. And this information is literally coming from a step 1 question where I believe the other answer choice was wearing sterile gloves and a gown, and you don't need sterile gloves for this. It was a really annoying kind of question, but you can just wear non-sterile gloves and a gown to prevent transmitting C. difficile from one patient to another. So that's something. And washing your hands with soap and water is a given. Difficile cannot compete with the normal gut flora, but most people in the hospital are taking antibiotics such as clindamycin, so they don't have a normal gut flora. The clean hands sign, this sign right here, is there to remind you that clindamycin caused the diarrhea, depicted by the machine showing poop under the sign, right? So this chocolate that's coming over here is really supposed to resemble the poop from the diarrhea. And that's going to fall into place soon enough. We're going to see why it's like this over here. But really, the issue... Yeah, it's a really annoying question on UWorld. I mean, you do need to wear gloves so you don't exactly, touch them and pick stuff up and give it to another patient. But wearing non-sterile gloves and a gown is just, generally speaking, a thing you do with spore-forming bacteria. That's just a general thing, but they don't really talk about it enough, and they definitely don't talk about it in first aid. So the clean hands reminds you of clindamycin, as well as the fact that clindamycin causes diarrhea, as well as the fact that you need to wash your hands with soap and water. Workers need to wear gloves and a gown, but the masks these guys are wearing only depict the anaerobic character of all Clostridia. You don't need to wear a face mask, right? It's not transmitted by breathing it or anything. So the masks that these guys are wearing are just representing the same thing as all the other masks for all Clostridia, that they're obligate anaerobes. Hospital masks are only required for TB, varicella, and other such agents who you can transmit by breathing. There are two exotoxins, A and B, represented by the workstation's labels of apples and black licorice, right? So A and B. A for apples over here and B for the black licorice, and they're perfect to use the way they are because you're going to see it falls into the story. So the employees brushing the apples and it leading to the poop chocolate depicts that it tells you about the exotoxin A targeting the brush border and causing watery diarrhea. So they're brushing the apples, which reminds you of brush border, right? And that's the brush border not working correctly because of exotoxin A is why you get diarrhea. Exotoxin B disrupts the cytoskeleton integrity by depolymerizing actin, right? So that's why these licorice sticks that look like actin polymers are the perfect thing to use, leading to enterocyte death and necrosis and forming a yellow-gray pseudomembrane. So he's wrapping up all the licorice in this yellow plastic, which is supposed to remind you of the pseudomembrane. The guy is covering the licorice in a yellow plastic pseudomembrane. The diagnosis is made by visualizing the pseudomembranes or searching for toxins in the stool with polymerase chain reaction, shown by the kid in the chocolate and the lady pulling out his shoe, which is the toxin, apparently, right? So this one over here is basically the pathology doctor doing a search of the stool and finding what's causing the issue, all right? Need oral vancomycin, not IV. So you can see this van back here, right? The van in the back, it actually has a little thing over here that looks like a tongue. It's supposed to be a ramp, but it looks like a tongue because you have to give oral vancomycin, not IV, right? The train is always a symbol of metronidazole, which is the other treatment, metronidazole. Every time you see the train, think of the metro, which reminds you of metronidazole. Metronidazole is generally speaking used for things above the diaphragm, right? Clindamycin is for things below the diaphragm. So that's another way to remember stuff like that. And over here, C. difficile is notorious for nosocomial diarrhea. It is weak and won't be able to beat the normal intestinal flora, but hospital patients are usually on antibiotics, so their gut flora is not there. Right? So that should always remind you of the fecal microbiota transplant. Now, this is the other question about fidaxomicin. It was hard for many of the students because they just didn't remember this one medication that literally is just for this one case. A 62-year-old man is hospitalized with severe abdominal pain and diarrhea after a recent UTI. In the past year, the patient has had 2 episodes of C. difficile colitis. His medical history is also significant for diverticulitis and upper GI bleeding. He's allergic to penicillin, so you don't give him penicillin, but it's not like penicillin was the treatment for this anyway. An appropriate workup confirms C. difficile colitis, so they did the workup. The patient is placed on an oral macrocytic antibiotic that inhibits the sigma subunit of RNA polymerase. Right? So this is what they told you in UWorld. The mechanism of action of some medication which inhibits the sigma subunit of RNA polymerase. Which of the following agents was most likely administered? And the answer was fidaxomicin. Fidaxomicin has something to do with RNA polymerase. 31% of the people got it right, while 33% of people chose metronidazole, but you should know that has nothing to do with mRNA or RNA polymerase. And 15% chose vancomycin, probably because this is a medication being given orally. Otherwise, neither does vancomycin have anything to do with RNA polymerase. Fidaxomicin is administered orally and has minimal systemic absorption, resulting in high fecal concentrations. It also has a narrow spectrum of activity on normal colonic flora compared to the other 2 choices. And the last thing is, realize that this person had a UTI, right? Urinary tract infection, and I just told you he must have been probably given clindamycin because clindamycin is given for infections below the diaphragm, generally speaking, UTIs. There's a question that says some nurse gets infected and another, it depends on your intestinal biome. Yeah, UWorld's getting very creative, and they do keep making newer questions, but I haven't been able to access newer questions. I'm not gonna pay for that shit. But yeah, I mean, if I did still have access to UWorld, then I would definitely look at the newer questions to see what's changing. But most of the UWorld questions I have here are either from very recent screenshots someone sent me because they needed help, or from my own UWorld, which was over 2 years ago. Now the next guy, another big guy, C. diphtheria, right? Corynebacterium diphtheria. You need to know everything about diphtheria very well because this is also very high yield. There aren't that many gram-positive bacteria compared to gram-negative bacteria, so you have to make sure that you know all the gram-positive bacteria very well and that you can redraw the gram-positive algorithm. So Corynebacterium diphtheria, gram-positive rods occurring in angular arrangements, right? Which really doesn't get tested much, but angular arrangements, sure. Transmitted via respiratory droplets, causes diphtheria via exotoxin encoded by a beta prophage. The potent exotoxin inhibits protein synthesis via ADP ribosylation of elongation factor 2, leading to possible necrosis in the pharynx, cardiac, and CNS tissue. Symptoms include pseudomembranous pharyngitis, which produces this grayish-white membrane that you see in this picture, and it's usually not that obvious, but it does make this grayish-white membrane, with lymphadenopathy, myocarditis, and arrhythmias. So you could already tell C. diphtheria is really, really bad, right? Because of the CNS and cardiac aspect. Just the pharyngitis was good enough, but now you have these really scary symptoms. Lab diagnosis is based on gram-positive rods with a metachromatic granule, right? So metachromatic granules and a positive elect test for the toxin. So this image I put here is showing you what the positive elect test is supposed to be. And I'm going to talk about that, but this is what the positive elect test is going to look like. And the other thing is, just remember the metachromatic granules. There's no other gram-positive bug that has metachromatic granules. So C. diphtheria is the only one. Coryn means club-shaped. Metachromatic granules in Loeffler media, right? So Loeffler is the media you have to remember for this guy. Black colonies on a cystine tellurite agar, both of which are different kinds of media or agar that we talked about when we did the first microbiology video, right? The basic different agars you need to know for all the different bugs. And the book also has A, B, C, D, E, F, G to remind you all the things about C. diphtheria. So ADP ribosylation, beta prophage, CD is Corynebacterium diphtheria, and then elongation factor 2, and the granules, which are metachromatic. Now, if you look at the sketchy micro image, then you see everything else you need to know. So let's take a look at that. Okay. Alright, so it's called Corazon de la Corrida, which is Spanish for heart of the run, I guess. Corazon is heart in Spanish, right? So that's supposed to keep in mind the myocarditis aspect. The violet hues tell us it's gram-positive, and it's often described as having a club shape with a Y or V formation containing metachromatic granules that stain with aniline dyes, depicted by the guy holding the maracas, right? So this guy right up here, he's holding these colorful maracas. The exotoxin has an A and B subunit, active and binding. ADP ribosylation of elongation factor 2 is noted by the man with the green bow and elongating accordium. So this guy. You're going to see an accordium and a green bow in another image that has the same mechanism of disease, which is in Pseudomonas. Right? Pseudomonas also has a guy with a bow and an accordium for the same exact reason. The thick gray pseudomembrane is depicted by the kids eating gray cotton candy, right? So you can see they have this gray cotton candy on their tongue, both of these kids here, this one over here, right? The infection is transmitted by respiratory droplets, and it colonizes the oropharynx and can cause airway obstruction. It may even cause lymphadenopathy, leading to a bull's neck, depicted by the bull and his respiratory droplets, right? So this bull right here that's about to do the race. In the bloodstream, the toxin can have systemic effects like myocarditis, arrhythmia, and heart block, hence the title, right? Corazon. This is also depicted by the bullfighter's heart-shaped cape, right? The cape just happens to be floating in a shape that looks a lot like a heart. Diphtheria toxin can also damage the myelin of nerve fibers, depicted by the man eating the sausages that resemble myelin, right? So these sausages are going to show up again in Guillain-Barré as well. And that usually shows myelin damage. Definitive diagnosis requires culturing the toxin assay from a swab of the grayish membranes on tellurite and Loeffler's medium, depicted by the large telly display and the laughing kid. So what you're supposed to remember here is the telly here is the tellurite, cystine tellurite agar, Whereas this laughing kid that's not eating cotton candy, he's just there for the laughing or Loeffler part, right? So it's a little harder to remember the Loeffler based off of just this kid, but the telly part definitely sticks, alright? So if you see Loeffler and Telluride, those are the agar related to C. diphtheria. Differentiating between a toxic and non-toxic strands is done by the ELEC test, depicted by the bull's tongue licking itself. ELIC or ELEC test, something like that. Of course, that really doesn't work for me either. The tongue and him licking itself, I never remember that as something related to the ELEC test. But when I looked more about the ELEC test, then I had done my research about the ELEC test, so it stuck to me that it's for C. diphtheria. So it's a whole different personal learning process right there. The toxoid vaccine consists of inactivated exotoxin bound to a protein, often given with tetanus and acellular pertussis, like we talked about earlier, the Tdap, and causes an IgG response depicted by the green syringes, right? So these are the green syringes on the bull's neck. So that's the vaccination aspect. Green for G, and to match the green bow, which represents the toxin, right? So Tdap will always be important to remember for all three of those guys. Acellular pertussis is the only one we haven't done yet. So the ELEC test, what it is you see this filter paper. The filter paper is in the middle, the vertical one. It has C. diphtheria antitoxin on it. All right. Now, if you take a toxigenic C. diphtheria and line it like this red one is, horizontally over the vertical line, you see this precipitating line, right? That's the positive ELEC test. Then you take this unknown one from a patient, and it's also showing you the same lines forming. Then you know that the patient has a toxic C. diphtheria, right? Whereas if the patient had a non-toxic C. diphtheria, then you can see this one, the yellow strand, doesn't make any precipitation lines, right? So the presence of precipitation lines in an ELEC test is a positive ELEC test, which tells you that it is a toxic strand. And that's something you can get in a question, although I have not yet seen it, right? But it's mentioned in first aid, so you definitely should know it. The other note I have up here is diphtheria exotoxin has an active A unit and a binding B unit. This is from UWorld. It can colonize the posterior oropharynx and cause airway obstruction. Lymphadenopathy may lead to a bull's neck, and the toxin can cause systemic defects leading to myocarditis, arrhythmia, and heart block. The toxin also damages myelinated nerve fibers, leading to paralysis of the posterior oropharynx, so you're going to have trouble swallowing. Telluride and Loeffler's medium can both be used to diagnose a swab of the Graves' pseudomembrane. The ELEC test helps differentiate between toxic versus non-toxic strands, right? The toxic strand is the one that's going to have the precipitating line. Non-pathogenic strands can acquire virulence via bacteriophage-mediated infection with the Corynebacterium tox gene via lysogenization. Right, so this is a little topic that was discussed way in the beginning. So if you have a non-pathogenic strand, right, remember they're stressing this one thing for C. diphtheria, which is the beta prophage, right? That's what's causing the exotoxin to be encoded, right? Exotoxin is encoded by the beta prophage. So if you have a non-toxic, non-pathogenic C. diphtheria, and then something happened and now it's not so non-toxic anymore, that means it took the beta prophage from another bacteria. And that process of doing that is lysogenization. All right, so that's probably something that was in the UWorld question, which is why I put it here. And I didn't really remember that right now, but now that I've looked at it, it'll definitely stick to me for sure, because the beta prophage, A, B, C, D, E, F, G is definitely a very important thing to remember for this guy, and the B doesn't really stand for anything else but the beta prophage. All right, so that's C. diphtheria. Then you have Listeria monocytogenes. Now, Listeria looks like this, so you already know it's extremely tiny, right? So although it is gram-positive, it's a facultative intracellular rod. Intracellular, so you're not always going to see bugs in the patient. Acquired by ingestion of unpasteurized dairy products and cold deli meats. Transplacental transmission is also there by vaginal transmission during birth. It grows well at refrigeration temperatures, something that can be described in a question, right? 4 to 10 degrees Celsius. And this is also the same reason why unpasteurized dairy products that are going to be cold in the fridge or cold deli meats are also possibly carrying Listeria. It is able to form rocket tails, right? And that's the red parts of these images right here. Rocket tails is showing red because they've actually stained for actin, right? Rocket tails via actin polymerization that allow intracellular movement and cell-to-cell spread across cell membranes, thereby avoiding antibodies. Characteristic tumbling motility in broth. Can cause amnionitis, septicemia, and spontaneous abortion in pregnant women. Granulomatosis infantis septica is a disease that can be an answer choice or described. And what it does is basically you're going to see granulomas and sepsis in the same infant. So it's a pretty well-named disease. It can also cause neonatal meningitis, very much like strep agalactiae. Meningitis in immunocompromised patients, so elderly patients. Mild self-limited gastroenteritis in healthy individuals. Treatment is ampicillin. So what's happening with Listeria monocytogenes? Well, there's two notes I have here. Able to lyse the vacuolar membrane through the action of Listeriolysin O, a pore-forming toxin that is selectively activated within acidified phagosomes. An intact cell-mediated immune response is necessary for the elimination of Listeria. And then the bottom I wrote, this is the third most common cause of neonatal meningitis. Right? In order, they are group B strep agalactiae and E. coli. Those two guys are able to cause neonatal meningitis. This is the third guy that can cause neonatal meningitis in order of most common, and can cause meningitis in the elderly. Right? So the meningitis in the elderly. Now, meningitis, very much like pneumonia, is another topic that is going to have multiple bugs in the answer choices, and they're all capable of causing the same disease. Right? So if you have an elderly patient who's slightly immunocompromised, maybe he ate something that was, either unpasteurized milk or cold, and they mentioned something about the cold, not the weather, but whatever he was eating is cold, then you want to think of Listeria and meningitis in the elderly. We give vancomycin and ceftriaxone to cover gram-positive, but we must add ampicillin to deal with Listeria. So what this sentence is telling you is that if you ever get an elderly patient who has meningitis and you need to start treating them immediately, you will give them vancomycin and ceftriaxone, right? That'll cover the gram-positive and negative guys, but you have to also give them ampicillin just in case it was Listeria that caused it, right? So that's a very important little thing that can definitely pop up. On the top, I wrote that Listeria is also catalase positive, which they, for some reason, just didn't add to the book. So it is catalase positive, which means it's got the relation with the lack of a respiratory burst in CGD patients, right? No NADPH oxidase. So let's look at the Listeria image. This is right here from Sketchy Micro. Ooh, okay. Hold on, let me find that picture again. So since it's such a big file, sometimes some pictures just tend to become deleted. It's really weird that it does that. Okay, Listeria. Copy. So you could tell that the big picture kind of disappeared. Okay, so I'm just going to delete this, put this here, and then make it big. There you go. Alright, so let's take a look at what's happening with Listeria. Alright, Santa's list. So very important that this is a Santa thing, because Santa Claus is supposed to remind you of the elderly patients with meningitis, and I'm going to get to that as we talk about this picture. But so far we see the pregnant woman, the little kid, and Santa Claus. Listeria forms a narrow zone of hemolysis when plated. So the B light bulb depicts that it is beta hemolytic. Right, you can see that up here. Listeria is motile and facultative intracellular. Outside the cell, it uses flagella, and under light microscopy, it has tumbling motility, depicted by the light bulbs tumbling down the tree. Right, so you see all those purple light bulbs that actually look like Listeria. And they're purple and elongated, reminding you it's gram-positive bacillus. Inside the cell, it rapidly polymerizes actin against the bacterial cell wall to propel itself in the opposite direction. So it's called an actin rocket, represented by the toy rocket present. Right, so that's the toy rocket present right here. Okay. The cat represents catalase positive, which is right here. It's playing with one of the toys. With one of the light bulbs, I mean. The icicles outside are to depict the cold environment that Listeria can survive and multiply in. So you're thinking of cold meat and cold milk and stuff like that. Thus, they contaminate refrigerated milk and soft cheeses depicted in the image, right? So this This is a little tradition people do for Santa Claus, right? During Christmas, you put out milk and stuff for Santa Claus, so when he visits, he leaves the gifts and drinks the milk and cookies. So they also have a soft cheese here. Thus, they contaminate refrigerated milk and soft cheeses depicted in the image. Pregnant women are more likely to get infected, and it can lead to early termination, or if later, it can lead to newborn disease. So pregnant women avoid soft cheeses, right? Infants avoid honey. Pregnant women avoid soft cheeses. This is the third most common cause of meningitis in neonates, after group B strep agalactiae and E. coli, depicted by the meningitis helmet, right? So again, a kid wearing a helmet like this is always about neonatal meningitis. And we're going to see that in E. coli as well as many other gram-negative bugs as well. Listeria also causes meningitis in adults over 60, and we give them vancomycin and ceftriaxone to cover gram-negative and gram-positive respectively, but we also give the elderly ampicillin to cover Listeria. So remember, Santa Claus is getting meningitis, and he's also wearing a red hat, so it does help. And he also has the Actin rocket in his bag, so you could think of him being infected. The AMP, another gift over here, is to remind you of ampicillin, which treats Listeria. Alright, so that's pretty much it for Listeria right there. The last two guys are on this page are Nocardia and Actinomyces, often spoken of together, right? Because they're both branching filaments, right? They both have branching filaments, which makes them look a lot less like bacteria and more like fungi. But they are bacteria. They're both gram-positive bacteria. Nocardia and Actinomyces. Now let's look at Nocardia first. So Nocardia is in the middle. Actually, let's look at Actinomyces first. It's easier. So Actinomyces is this guy. There's Actinomyces israeli. There's a couple other Actinomyces as well. All Actinomyces are anaerobic. So again, anaerobic, you have that black mask right there. Anaerobic. It's also not acid fast, right? It's not acid fast. So you can see it's staining pretty well, right? Acid fast things don't tend to stain that well, right? But B is acid. It's not acid fast. Actinomyces actually stains pretty well. Normal oral, reproductive, and GI flora. So you and I both have Actinomyces in our bodies. It is able to cause oral facial abscesses that drain through the sinus tracts, often associated with dental caries, extraction, and other maxillofacial trauma. It forms yellow sulfur granules and can also cause PIDs with IUDs, right? So pelvic inflammatory disease with intrauterine devices. PIDs with IUDs. So what are we seeing in this image? Well, for one thing, last thing here was treat with penicillin. So he's a soldier, right? He's writing with a pencil for penicillin, and he's wearing this thing around his face because he probably got hit in the face with something. So that reminds you of the maxillofacial trauma, right? Now the draining tract is shown by this. You see how this is draining water or something? So that's your draining tract right there. But this image is how it really looks like, right? So it's a random tract. It's a random oral abscess that's actually draining something out of it. So you'll see stuff coming out of it, right? So it's usually after some kind of oral maxillofacial trauma. But you can also just get a question about a woman presenting with PID, and she does have an intrauterine device, and they might be like, you can't really see any, or they'll describe that you see branching filaments, which would pretty much be a giveaway for Actinomyces, but they might just describe that you don't see characteristics of other common things that cause pelvic inflammatory disease, right? So that's Actinomyces, pretty straightforward. Dental caries, PID, and sinus tracts that are draining sulfur granules, right? Sulfur granules are depicted by all these yellow rocks all over the place. This tree is supposed to remind you that it's a filamentous, gram-positive filament, right? So branching filaments. So that's what the branching tree is for. Now, Nocardia is a little more complicated. So this is Nocardia right here, right? The actual guy Nocardia is him, right? And then these are other. These are not the protagonists. The only protagonist in the image is this guy, right? Then these are other things about Nocardia. So let's see what Nocardia is all about. Nocardia is an aerobe, right? So anytime we see an aerobe, we're going to see the aerobello, which is this thing right here, right? An aerobello is actually used like this to make air and turn a fire on or keep the fire running. So that's what the aerobello is for. It is an aerobe, which already is one difference between the two. Nocardia is also acid fast. So you can remember the no in Nocardia as in you can't really visualize it too well, right? Acid fast. It's very weak acid fast, but it's still acid fast. And acid fast is always going to be depicted by this pink gun. If you see a bug that's acid fast, someone in that image is going to be holding a pink gun. Causes pulmonary infections in immunocompromised. Can mimic TB, but with a negative PPD. Cutaneous infections after trauma in the immunocompetent. And it can spread to the CNS, right? Nocardia really likes the brain. So there's a difference between immunocompromised and immunocompetent. If you see pulmonary infection, the patient better not be immunocompromised if it's not nocardia. For nocardia, pulmonary infection only in immunocompromised patients, right? And the other thing is cutaneous infection. Now, cutaneous infection, it can occur in both people. Obviously, it can occur in the immunocompromised for sure, but it can also occur in the immunocompetent. So even if you're immunocompetent, nocardia can cause superficial issues on you, but not pulmonary infection. Treat this with sulfonamides, trimethoprim sulfamethoxazole. So SNAP is a pretty good way to remember it. Sulfonamides for nocardia, actinomyces, you use penicillin. So look at this image now. Let's see, we'll put this right here. Make this a little bigger. Put this right here, and let's talk about it. So this image is called No Card Game for Old Men, Nocardia. This is also a gram-positive filamentous branching rod. So the actinomyces tree is actually over here now as a painting. Nocardia is an obligate aerobe represented by the same air bellow that we saw in Bacillus anthracis. Right? Remember, Bacillus cereus was spores. Bacillus anthracis is also spores, but it's going to be the aerobic one. Cereus was also aerobic. And then Nocardia were anaerobes, right? Sorry, Nocardia is aerobic. I meant Clostridia. Clostridia were anaerobes. So Clostridia was the one that had gas masks like this. And Bacillus had air bellows. And over here, the Nocardia guy has air bellows, and Actinomyces has the mask for being anaerobic. So that's that. Nocardia is found in the soil, depicted by the cactus pot spilling its soil. Right, so that you see right here. And we saw the spilling of soil also in Clostridium perfringens. Nocardia stains weakly acid fast thanks to the carbofusion stain that is taken up by mycolic acids depicted by the cowboy shawls with tassels that look like mycolic acid. Right, so the little tassels here on his shawl are supposed to resemble mycolic acid in the membrane. Right, and it's acid fast, which is depicted by the pink gun, the fuchsia colored gun and holster. The cat depicts that as catalase positive, which is important for patients with chronic granulomatous disease, right? They can't battle this. The ammonia spray bottle in the middle reminds you that this is also urease positive, which is obviously a much bigger deal for, what was the other bug? The one that causes the struvite stones. Skipping me. But you guys should know. So if you know it, say it. The ammonia spray bottle. Okay, so we talked about the urease thing. The other player depicts the pulmonary, CNS, and cutaneous symptoms, which is this guy. Right, so he's obviously about to lose pretty badly right now. The walking stick that he's using, and walking sticks in general, will always be about immunocompromise. Pulmonary nocardiosis will manifest with a pneumonia with lung abscesses, depicted by the cough and the bullet cavitating his chest. This one right here. Nocardia can disseminate and prefers neural tissue, depicted by the second bullet going through his hat. So that up here, right, it went through his hat, so that's for the neural part. Yes, Proteus mirabilis, thank you. The Proteus mirabilis is where the urease positivity is the bigger deal. Any exposure to soil can cause cutaneous nocardiosis, depicted by the reddened cow spots for the indurated inflammatory skin infection. Right, so so his cow spots are actually not red. Why did I write reddened? Or maybe they were red in the video. I'm not sure. But either way, the cow spots are supposed to remind you of the skin infection they can cause. And skin infection can occur even if you're immunocompetent. Treatment is with sulfonamides, which is always depicted by rotten eggs. Right? Trimethoprim sulfamethoxazole is always going to be represented by rotten eggs. You're going to see that in other pictures as well. All right? So that's your Nocardia and Actinomyces. So Nocardia was a little more information there. It can cause pulmonary infection and it's acid fast. It's very much like TB, but without the PPD, right? Because it's not TB. Actinomyces, you just want to think of the maxillofacial trauma. These images here are just showing you cutaneous nocardiosis, but it's very unlikely that you're going to get, an image asking you for, you to be able to tell, oh, this is cutaneous nocardiosis. They would have to tell you a little more information than just that. The URL question in the middle is pretty simple. It's a 54-year-old woman presenting with dyspnea, productive cough, fatigue, and night sweats. She had renal transplant 2 years ago and is on immunosuppressive therapy. So she's immunocompromised and old. Temperature is 101 F. Blood pressure is 130/80 and pulse is 90. Chest x-ray has nodules. And the brain MRI has... Let me make this a little smaller. There you go. Okay. And the brain MRI has a 1.2 centimeter ring enhancing lesion with edema in the right frontal lobe. Sputum grains show a branching gram-positive organism, and that's the giveaway, right? Branching gram-positive organism, you have the pulmonary infection and CNS infection. This has to be nocardiosis, and that's it. Right now, if they didn't give the sputum grains showing branching gram-positive organisms, you should still be able to pick it because it's the only thing, nocardia is the only thing that would cause both pulmonary infection as well as CNS spread. All right, in an immunocompromised patient. Does E. pylori? What's E. pylori? Let's see. Oh, H. pylori. Yes, H. pylori is also going to have the urease bottle in the picture. You're going to see that. Yeah. Obviously, you may... Sorry, my bad. But yes, H. pylori is also going to have urease as a thing in the image when we get there. But that's under gram-negative, so we haven't reached it yet. But it's great that nocardia is right before Mycobacteria because there's a lot of similarity, right? So we just talked about it being very similar to TB. So let's check it out. Nocardia had this cowboy guy, right, with the mycolic acid shawl and the pink gun, right? And this is always going to help you remember that it causes TB, similar to TB kind of symptoms, the pulmonary infection. Now let's take a look at actual Mycobacteria. Mycobacteria is a big topic. It's the whole page over here and two big images. Well, this is the image for it, but the image has a really big explanation. This over here is for Hansen disease, and that's different. So let's look at Mycobacteria. They are acid-fast, and not weakly acid-fast like nocardia, but actually very, very acid-fast. So they stain a very weird kind of pink, just like that fuchsia-colored gun. Mycobacterium tuberculosis is the one we're talking about when we need to discuss TB, and it's often resistant to multiple drugs. The other guys are much less talked about, but they're in the book and they can pop up in a question. So, Mycobacterium avium intracellulare, MAI. MAI causes disseminated non-TB disease in AIDS patients, which makes this a pretty important bug, I guess, right? Because AIDS is a pretty big deal in step 1. Often resistant to multiple drugs, just like tuberculosis. Prophylaxis is with azithromycin when the CD4 count goes below 50. Right, so there's multiple things you need to know about various CD4 counts. Right, if your CD4 count is below 200, below 100, below 50, there are different medications you need to get the patient started on as prophylaxis. So if you have an AIDS patient with a CD4 count below 50, you need to get them started on azithromycin just to make sure they don't get MAI infection. M. scrofulaceum is a very low-yield bug. I've never seen a question on it, but it causes cervical lymphadenitis in children. M. marinum is easy to remember because it has marine in it. It causes hand infection in aquarium handlers, right? So anyone that works in an aquarium, working with fish. All Mycobacteria are acid-fast, so they're going to be pink rods, as you can see in both of these pictures. Now, back to Mycobacterium tuberculosis. TB symptoms include fever, night sweats, weight loss, cough, and hemoptysis, which is a big deal. Cord factor creates a serpentine cord appearance in virulent M. tuberculosis strains. It activates macrophages, promoting granuloma formation, and induces the release of TNF-alpha. Sulfatides, which are surface glycolipids, inhibit phagolysosomal fusion, so they can't be destroyed. Right, so these are the two things, the cord factor and the sulfatides. Those are two big things that allow Mycobacteria to survive within humans. Right? Mycobacteria are obligate aerobes. They need air. TB survives and proliferates in macrophages just like salmonella. Cord factor is a glycolipid in the TB cell wall. They cause the bacteria to clump into serpentine cords and are essential for virulence. Lack of cord factor means the bacteria is not virulent. The sulfatides are what allow TB to survive inside macrophages. So then they go to talk about tuberculosis, and you need to know how the PPD test works, you need to know about BCG vaccinations, and you definitely need to master caseating versus non-caseating granulomas. Tuberculosis, PPD positive if current infection or ever had an infection, right? If a patient was ever infected with TB, they will have a positive PPD for life. The PPD will always be negative if they did not have infection or in sarcoidosis, right, as well as an HIV infection, especially with low CD4 counts. So PPD being negative doesn't always tell you for sure that this patient in your question never had a TB infection and currently doesn't have TB infection. You have to also make sure that they don't have sarcoidosis, and you have to also make sure they're not HIV patients. Remember, HIV can stay dormant in a person for up to 10 years. Right? Anyone can have HIV and not have any symptoms until HIV finally decides to cause AIDS. Interferon gamma release assay, IGRA, interferon gamma release assay, has fewer false positives from a BCG vaccination. Right? So that's a pretty common issue that comes up. People with BCG vaccination often tend to have false positives when you do a PPD on them. So the only other thing you can do is do an interferon gamma release assay to make sure that it was because of a vaccination and not that, they were infected or are infected. Caseating granulomas with central necrosis and Langerhans giant cells are characteristic of secondary tuberculosis. Secondary. Right, so caseating granuloma and giant cells. So what's happening? What is secondary tuberculosis? We'll get there. So Mycobacterium tuberculosis comes in, right, goes to the hilar nodes, and it makes something known as a Gone focus, which is usually on the mid to lower lobes. And that makes sense because this is kind of like swallowing a nut, right? Things that you eat or mistakenly swallow and it goes into your bronchioles will go on the mid to lower lobes. So a Gone focus is usually going to be on the mid to lower lobes, but the involvement of a hilar node and the Gone focus is a Gone complex. And these are two words that are definitely very much just about TB, and they definitely show up. Now that is going to lead to primary tuberculosis, right? Primary tuberculosis, and then 90% of primary tuberculosis is just going to heal by fibrosis and calcify, and this patient will have a positive PPD. Eventually, it'll reactivate, maybe because the person got really sick or something, and when it reactivates, right, two things can reactivate it, either because the person got really sick or they started taking a TNF-alpha inhibitor, right? You never give a person a TNF-alpha inhibitor without checking for PPD. So now it reactivates. When it reactivates, that's the secondary tuberculosis. And secondary tuberculosis will always be on the upper lobe. Right? And this is not something you have to memorize. What you have to memorize is that TB or Mycobacteria are obligate aerobes. They like air. And the upper lobes is where you have the most air, right? Because air is going to be up there. There's a lot of ventilation in the upper parts of the lung, but low perfusion, right? High ventilation, low perfusion. So there's a lot of air up here that your own body is not picking up because there isn't enough blood up here. So that's where tuberculosis likes to go when it reactivates, when it chooses where it's going to go. Whereas up here, it didn't choose where it's going to go. It's just how it went because that's how air comes in. And in secondary tuberculosis, you also get involvement of other organs, right? So you can get the cavitary caseation and scar in the lung, but you also get caseation in the kidney, right? So that's a pretty big deal. And then it also starts causing bacteremia through blood, and it travels to other parts of your body, leading to something known as miliary tuberculosis. So it involves the meninges, the vertebra, right? And when the vertebrae are involved, that's pot disease. It can also go to lymph nodes and travel to your liver, spleen, adrenal gland, everywhere, right? Joints and long bones, everything's going to get messed up if it leads to miliary tuberculosis, right? That was 90% of the cases. Primary tuberculosis itself could just go ahead and become progressive primary tuberculosis if untreated, if you're malnutritious, right? If you don't eat well, or if you have AIDS. So those are other scenarios that you need to watch out for. On the top up here, remember to do a PPD on someone before giving them a TNF-alpha inhibitor to prevent the reactivation of TB. The only thing keeping a macrophage there, the only thing keeping a granuloma there is TNF-alpha. TB cultures very slowly, requiring up to 6 weeks. It requires something known as the Lowenstein-Jensen medium, which we talked about in the first microbiology video, where it makes a cauliflower-like colony. The interferon gamma release assay takes white blood cells from the patient and adds TB antigens different from the ones used in the BCG to see if the white blood cells make tons of interferon gamma. It cannot differentiate between a latent and active TB infection, which is a little fact that you need to know about the interferon gamma release assay. And an interferon gamma release assay cannot differentiate between latent and active TB, but a PPD can, right? And actually, no, neither can PPD, right? PPD is going to be there even if you have current or past exposure. PPD is going to be positive if you ever had TB, whether it be before or now. The only real way to figure out if you have positive current infection or if you have latent infection really doesn't exist, right? You get a positive PPD, but you look fine and you're not sick, that's your latent infection right there. That's really all there is that you could do. Other than that, there's really no other way to figure out if someone has latent infection. But it'll be very obvious if you have current infection, right? Because you're going to have hemoptysis and night sweats and stuff like that. In miliary tuberculosis, we talked about how it involves the vertebrae and many other parts, right? In bones, TB causes Pott's disease, also known as tuberculosis spondylitis. This affects the thoracic spine, and on radiograph, you note lytic destruction of the anterior portion of the vertebral body. You will see leukocytosis and an elevated erythrocyte sedimentation rate, telling you about inflammation. In the CNS, you note meningitis and potentially a cavitary tuberculoma in the brain. Treat with RIPE, and we do need to know the treatment regimen for tuberculosis. Okay, so let's look at the tuberculosis image right here. M tuberculosis. I believe this is a really big thing here. Yeah, there's a lot to it. Okay, so let's see what's happening. So here again in this image, let's just take a look at what we're seeing first, right? So we have this guy. This is our protagonist. This guy over here on the left is your M tuberculosis. There's this guy inside who's in what looks like jail, right? But it's actually a macrophage. There's this other shooter here. They're shooting at each other. There's this person that's held captive and this person that's just fallen asleep. So what's happening? Let's take a look. M tuberculosis, the image is titled Shootout at the TB Corral. TB stains acid fast and takes up carbofuchsia stain, symbolized by the acid fast quick draw gunslinger with his fuchsia gun and two branched tassels. So he's got all the little tassels just like we saw in Nocardia, and he's got the pink gun again and the holster. Compared to Nocardia, TB is strongly acid fast. TB cultures very slowly, requiring up to 6 weeks on Lowenstein-Jensen medium, which inhibits the growth of other bacteria. This is the name of the store, right? Lowenstein General Store. The air bellows, right? The air bellows sign right here. The air bellows sign on the right side of the store depicts that TB is an obligate aerobe. TB is transmitted from person to person by respiratory droplets and proliferates in macrophages, depicted by the macrophage cage that will also be used in Salmonella. We're going to see the same kind of thing in Salmonella as well. The Mycobacterium cell wall has glycolipids that cause it to clump into serpentine formations essential for virulence. This is the cord factor, which protects the bacteria by forming granulomas by upregulating TNF-alpha and causing more macrophages to act. So that's... Oh, okay. So that was a conversation about cord factor right there. The next thing is your sulfatide. Right, so where are we? The last virulence factor are sulfatides, which prevent phagolysosome fusion, accumulating in lysosomes and creating incompetent lysosomes, depicted by the dust clouds that are not combining. Right, so these little dust clouds right here are supposed to show you phagolysosomes, and they're all individual. I think that's a pretty weak visualization of that aspect. So do your best to remember sulfatides. The cord factor is really easy to remember with the lasso and all that, but not the dust part. That part I always forget. But I always remember the Sulfatides, that I remember. Phagolysosome fusion not working, I remember that. But I can't remember this one thing from the image. The other things I remember just well, though. Once someone is infected, people have a primary infection which can become a healed latent infection, a systemic miliary infection, or later reactivate. The primary infection heals and calcifies and forms a Gone complex in lungs, depicted by the cactus on the left. And you can see how it's on the middle lobe. Right, it's on the middle lobe. So these two are showing you your lungs, right? 3 lobes on the right, 2 lobes on the left, etc., etc. And it's in the middle lobe on the right lung over here. That's your primary infection. 3 lobes on the right and 2 for the left lung, with bullet holes in the middle right lobe and red dots for the Gone complex, right? So the red dots are hilar part of the Gone complex, the hilar nodes. This stuff right here. This causes a caseating granuloma. The broken carts are necrotic macrophages, and the potatoes, which are tubers, are in them. So these broken carts basically try to show you macrophage dysfunction. And making granulomas, so that's why there's grains falling out of all of them. Granuloma for grains, or grains for granuloma. Primary infection has nothing more than a fever in children of endemic areas, depicted by the sleeping kid for a latent infection, and the shovel is going in the ground like a positive TB skin test, which is also positive in people with the BCG vaccine. So over here, you're basically seeing what would be, your initial infection, right? And this BCG vaccination and the shovel are showing you that people with the BCG vaccination give a positive, because there is a bump, a positive PPD test. That's a little fact that you can get a very basic question on. And this kid is sleeping because it's latent infection, it's not active infection. Reactivation is rare unless the patient is immunocompromised, leading to a downregulation of TNF-alpha, depicted by the bound, defenseless guy tied to TNF-alpha. So this is supposed to be TNT barrels, right, for explosives, but it's just labeled TNF, and this guy is pretty much helpless, so he's immunocompromised. If you want to start a patient on a TNF-alpha inhibitor, always screen them with a PPD to check for potential reactivation of TB. Reactivation affects the upper lobes, depicted by the lung cactuses on the right side, right? And then here you can see it's on the upper lobes now. And your red dots disappeared, by the way. Right? So the red dots, the Gone complex, that was only a thing for your primary infection. Very important little fact that you want to make sure you remember. Right? Where are we? Yeah. So the Gone complex is only part of your primary tuberculosis. Right? But the reactivation ones do not have a Gone complex. Let me see. Where are we now? Okay, reactivation can also affect the skeletal system, upper lobes, night sweats, hemoptysis, depicted by the guy coughing in the jail. So he's coughing blood. That's what that is. Reactivation can also affect the skeletal system and the CNS. In bones, it can cause Pott's disease at the spinal column, leading to demineralization of the bone and soft tissue swelling. And that's depicted by these pots. Right? These pots that are stacking up, they look like your vertebral column, and they're all cracking up. Right, so that's what Pott disease is right there. CNS involvement manifests as meningitis or a cavitary tuberculoma in the brain, depicted by the guy taking a bullet to his hat, once again, just like the Nocardia stuff. Right? Treatment is with RIPE, but TB is capable of becoming resistant, depicted by the sign on the cart on the right. The R and I are highlighted because they're used for prophylaxis. Right, so this is RIPE over here, as in ripe food or ripe tubers, but RIPE is supposed to remind you of all 4 of the medications you're supposed to take in tuberculosis. Right? Rifampin, isoniazid, ethambutol, all those guys. And I think that's generally it for that. So, you got to watch out for all of that. Obviously, a very different kind of bug, and definitely a lot of pathophysiology as well as pathogenesis to talk about. But prophylaxis is just rifampin and isoniazid. That's also a little fact you want to make sure you remember correctly. I think that's about it. The last bug is your Mycobacterium leprae. It's also a Mycobacterium. So we're going to see some of the same things again. Right? Mycobacterium leprae. Leprosy, also known as Hansen disease, Mycobacterium leprae are acid-fast bacillus that like cool temperatures, right? They infect the skin and superficial nerves in a glove and stocking loss of sensation pattern, right? Glove and stocking. So just the hands and your feet kind of thing. Diagnosed via skin biopsy or tissue PCR. Reservoir in the United States are armadillos, right? Armadillos in the United States actually carry Mycobacterium leprae. Leprosy has two forms. Many cases fall temporarily between the two extremes. There's either the lepromatous form or the tuberculoid form. Now, the tuberculoid form, although TB is really, really bad, the tuberculoid form is actually alright. This is limited to a few hypoaesthetic, hairless skin plaques characterized by high cell-mediated immunity with a large Th1 type immune response and low bacterial load. Treatment, well, we'll get to treatment later, but that's all you see in the tuberculoid form. So now there's some immunology involved, right? This is an image from Euro talking about the immune response in leprosy, right? So you can see the Th1 one is the purple one, okay? And then the Th2 one is the blue one. So the purple one shows you Th1 response, and that's your tuberculoid form. So you can see what's happening is that you have a large Th1 type immune response, so there isn't much of a bacterial load. The bacteria are within cells. The lepromatous form can be lethal. It's really bad. So leprosy is lethal. The lepromatous form presents diffusely over the skin with leonine facies and is communicable, high bacterial load, characterized by low cell-mediated immunity with a largely Th2 response, right? So you can see here in this image what they're saying is bacterial load is increasing as you go from left to right. So low bacterial load is the tuberculoid leprosy, high bacterial load is your lepromatous leprosy. And as you go from left to right, you can see that the cell-mediated immunity must be decreasing. Right? If you have decreased cell-mediated immunity, you're going to get the lepromatous version. Right? And that's more humoral immunity. Humoral being with antibodies. Right? Cell-mediated is more important though. It's better to have the cell-mediated version working, but it's not necessarily going to be the case every time. And then you take a look at this question, you get to see what's happening. So 34-year-old woman comes to the office due to skin changes. Blotches of skin on her arms appear to be of different color, and she also has a tingling sensation in her hands. The symptoms have developed over the past several months. On exam, there are patchy areas of skin anesthesia and hypopigmentation on her upper extremities. Nerve biopsy, evaluated under light microscopy, shows many organisms invading Schwann cells. HIV testing is negative. Mycobacterium leprae is the answer here, right? So what do we see in this patient? The range of clinical manifestations depends on the strength of the cell-mediated immune response. This patient's tuberculoid leprosy is the least severe form and is often self-limited through Th1-mediated response. The most severe form occurs with lepromatous leprosy in patients with a weak Th2 response. Not Th2, what am I? In patients, in patients with a weak Th2 response, and these patients can have leonine facies, testicular destruction, and blindness. Alright, so you wanna see the last thing they talk about here is whether or not you're gonna have a positive Lepraman skin test, and that positive or negative Lepraman skin test really depends on the bacterial load, right? The amount of bacteria you can actually find. So the more severe form, the lepromatous form, is the one that has a negative Lepraman skin test, right? The tuberculoid form, you're going to have a positive skin test, and I think of it as getting TB. Getting TB is always going to have a positive PPD skin test, so getting the tuberculoid form of leprosy is also going to have a positive Lepraman skin test. Right? You get a question on that, and I think that's about it for leprosy. We could take a look at the sketchy micro image now. So let's see what they talk about here. And this is actually a pretty nice image too. It did help me memorize a couple good things. So our bad guy is actually both of these guys over here. Right, that's our protagonist for leprosy. There are snow and icicles because leprae thrives at cold temperatures. It shares the characteristics of TB, so it is acid-fast, depicted by the quick-shot gunner with the mycolic acid tassels and his fuchsia gun and holster. In the U.S., the armadillo is a reservoir for leprae, depicted by the armadillo named Hansen and the jail's name, right? Armadillo County Jail, and you have this armadillo right here. Armadillo County Jail. There are two clinical presentations. The tuberculoid form is presented in jail cell 1, representing Th1 response of cell-mediated immunity containing the bacteria within macrophages. Right, that's why you have a low bacterial load, and let me see something. Yeah, low bacterial load in the tuberculoid form, and a positive Lepraman skin test, just like in with the PPD, right? With TB in the PPD stuff, TB is within macrophages, but the PPD test is going to be positive. It's just they have a low bacterial load, right? So that's what's happening on this side, and this is why you have the vaccination stuff on this side too. Not the vaccination stuff, the testing stuff, right? This is just like the PPD test we had in Mycobacterium tuberculosis. Here on the tuberculoid side with Th1 response, we're seeing a Lepraman skin test giving a bump. Okay, so low cell count, Th1 response, everything is inside macrophages, low bacterial count, but you can see it when you do the Lepraman skin test. So Th1 response of cell-mediated immunity containing the bacteria in macrophages, so he's inside the jail. Right, jails are usually for macrophages like we saw earlier. Symptoms are mild, and mainly you note a demarcated hairless skin plaque that you can see on his head, basically, right? So this guy, he just has the frontal balding stuff. That's about it. But it can be anywhere. It's just for him, it was easier to draw it like that. The Lepraman skin test will also be positive, similar to a TB test. So it's depicted the same way with the shovel and dirt, right? With the tuberculoid form, just like with TB and stuff. Jail cell 2 represents the Th2 humoral response, and their Th1 response is weak, so they cannot contain the infection. Hence, the guy breaking out of jail. So I had a feeling that was actually a problem here, so let me just fix that. This question here, I can't really edit this anymore, but what this was supposed to say is the most severe form occurs with lepromatous leprosy in patients with a weak Th1 response. So what they use is just a Th2 response, but I can't edit that anymore. So let me just make a quick note on that, because when I was reading it I was like, that doesn't sound correct. Okay. Let me just put it like that. That way I can make sure I don't do that incorrectly. And that makes sense, because in the lepromatous version, what is happening is the use of Th2 response, but they don't have a Th1 response, and that's why things get really bad for them. They're unable to contain the infection within macrophages. So let's go back to where we were. Okay. Th2 humoral response, and their Th1 response is weak. So they cannot contain the infection, hence the guy is breaking out of the jail, right? He's escaped. The infection can go from human to human, hence they are holding hands, right? These two guys are holding hands here. The guy has a lionine face depicted by the lion bandana that he's wearing right there. The criminal's extremities are cold, so you note symmetric neuropathy. Symmetric neuropathy in a glove and stocking pattern, which is why he's got the black gloves and black shoes that you see. You will also see poorly demarcated lesions on extensor surfaces, because extensor surfaces are cold. Right? So that's why you see it on his knees and elbows. Weird demarcated skin lesions. And biopsy would show large amounts of bacteria, because the bacteria are not within macrophages. So their cell count is actually really, really big. Treat with dapsone and rifampin for 6 months, depicted by the rifampin rifle. A rifle is always for rifampin. And we saw the rifampin rifle in tuberculosis as well. And the deputy badge. Alright, so the deputy badge, the deputy part is for dapsone. Right, so this big deputy badge. You're never going to see that again. Dapsone is actually used for a couple other things too, but really it's just going to be for leprosy. So dapsone and rifampin. And the lepromatous version, which is more severe, needs another medication known as clofazimine. Right? In addition to dapsone and rifampin for 2 to 5 years, and even then their leonine facies might not get fixed up. So the clofazimine is depicted by the cloth that he's using right here to escape. That's clofazimine right there. And that's really it. Okay, so Th1, Th2, and Th1 you have macrophages that keep the infection inside. So you have a low cell count and a positive Leprae skin test. In Th2, it escapes. There's no macrophages. It's a Th2 response, so it gets really, really bad. Right? High cell count, but not a positive Leprae skin test. It'll be a negative Leprae skin test. Right? And that's really all there is for that. Last thing we have are two questions here, so let's take a look. One is UWorld and this one is AMBOSS. So what's happening? 48-year-old man dies in a motor vehicle crash. He had a history of IV drug use and had recently been released from prison. The patient's other medical conditions include hepatitis C and hypertension. Okay. On autopsy, he's found to have a small fibrotic focus in the upper portion of the lower lobe of the right lung and the calcified right hilar lymph node. These autopsy findings are most consistent with what? And they're most consistent with a primary M. tuberculosis infection. Both things are here. But remember, the Gone complex is only a thing for the primary infection, right? And they told you what they described is a Gone complex. They described something in the lower lobe, which is the primary infection, goes on the lower lobe. Secondary or reactivated infection goes on the upper lobes because TB likes air. And the hilar lymph node. The hilar lymph node being calcified is only a thing that occurred with the Gone complex. So primary tuberculosis. No one should have gotten this wrong. It was very evident that it's tuberculosis, right? But other than that, and it's tuberculosis because he is immunocompromised. Something's probably not right. Doing all these IV drugs, he might have contracted HIV. Who knows? All right, so that's what they continue to explain here. A fibrosed and calcified Gone complex is referred to as a Ranke complex. Another new word being described by UWorld. So if you see that, you know what you're looking for. The AMBOSS question here, 3 weeks after undergoing a transurethral prostate resection for BPH, a 70-year-old man has fever, malaise, and pain in his extremities. So fever, malaise, and pain in his extremities. Physical exam shows subungual... Why did the color change? That's so weird. Okay. Physical exam shows subungual petechiae and tender red papules on his finger and toes, which should make you think of all the things that you see with infective endocarditis. Right? A new holosystolic murmur is heard on the chest auscultation. A photomicrograph of a Gram stain of an isolate from blood culture is shown. So you're looking at the Gram stain. It looks like this, and that should ring a bell for what you see, because they're very clear in this image. The organism does not cause hemolysis on blood agar, so that tells you another really big thing, right? So it's gamma hemolytic, and that's pretty much a giveaway now at that point. Addition of PYR gives bacterial colonies a cherry red color, right? So it is PYR positive. Which of the following is the most likely causal organism? Presence of a new holosystolic murmur, oscillar nodes, and splinter hemorrhages is suggestive of infective endocarditis. Photomicrograph and blood agar culture reveal gram-positive cocci that are gamma hemolytic and PYR positive. Enterococcus fecalis is a gram-positive, PYR positive, catalase negative coccus that can grow in 6.5% NaCl and produces variable hemolysis on blood agar. It can cause subacute infective endocarditis in patients who undergo GI or GU procedures, and we talked about this in yesterday's video. So this guy did undergo a GU procedure with his prostate being removed. Enterococcus species are resistant to drugs typically used to treat infective endocarditis, such as penicillin G, first to fourth generation cephalosporins, and vancomycins. Enterococcus is sensitive to aminopenicillins and fifth generation cephalosporins like ceftaroline. Right, so Enterococcus, we saw tigecycline and linezolid in yesterday's images are treatments for that. So very important bug that can be described very specifically, as they did in this image. In this question stem. You didn't even need the image here. They could have just described this and you would know. Right, so PYR positive. They're always both things. So they are PYR positive and they are able to grow in 6.5% NaCl. But on top of that, being gamma hemolytic and causing endocarditis is a giveaway for Enterococcus, right? So the history. This guy just underwent a GU procedure. So everything in that question was yelling Enterococcus. Now, in tomorrow's videos, or whenever I stream again next, we're going to the gram-negative lab algorithm. A bunch of bugs that, again, you have to know just as well as the ones we just talked about. Extremely, extremely well. So thank you for joining, and I'll see you guys later on.